What does infertility mean? Can I ever have children? How long should we wait or try before we go see a doctor? And what is meant and what is the main treatment method for infertility? Hello and welcome. I'm your host, Dr. Molatelo Mainetje-Bossman. Signing with us today is Trifosa Nzolengwe. June is World Infertility Awareness Month, and the ideal time to increase awareness of the fact that infertility is a medical condition affecting a surprisingly large number of growing couples that are around the world. Now, this includes problems related to females as well as male fertility. During this month, several myths regarding infertility are debunked and a lot of options are brought forward to those who may want to conceive. On Vital Signs, we'll focus on infertility. Coming up on the program, we'll speak to a pastor and his wife about their journey with infertility. We'll speak to multiple international award-winning filmmaker and entrepreneur about her infertility journey and, of course, her documentary film, When Babies Don't Come. We'll speak to gynaecologist and obstetrician who's the head of Reproductive Medicine Unit at Stellenbosch University about infertility in men and women and a new modified in vitro fertilization procedure at a fraction of the price. And lastly, we'll speak to the head of Reproductive and Endocrine Unit at the Biko Academic Hospital and, of course, University of Pretoria about infertility, which is a practical concern of Africans due to social disgrace as well as exclusion. Remember that you can be part of the show by asking the guests that we'll have on any question that you have on your mind, or simply share your view with us on what we're discussing. The number to call is 011-714-5861 or 011-714-5877. Of course, if you have social media and you would like to use it, please share your thoughts with us on social media, on Twitter at SABC Vital Signs and on Facebook, SABC Vital Signs. We want to know and hear about your story, Vital Signs. We'll continue after this ad break. Welcome back to Vital Signs. I'm Dr. Molatelo Mainetje-Bossman. In South Africa, infertility occurs in 15 to 20% of the population. That's 1 in every 6 couples. What is worrisome is that the number keeps rising and doctors are uncovering more causes of infertility amongst men and women of childbearing age. Now, having a baby is one of the most exciting times in a couple's life, but for couples coping with infertility and infertility treatment, of course, conceiving a baby can be very trying. The physical, emotional, and financial stress of infertility, if you're not careful, could definitely hurt your relationship with your partner. So, and let's go on now to welcome our guests on the show. Welcome Pastor Jerry Zane and his wife, Karabo Zwane, who are here to talk to us about their journey with infertility. Good morning. Thank you so much for joining us.
Thank you for having us.
Lovely. Let's start with you, Pastor Zwane. Infertility. Can you take us through the journey that you had from the beginning, when you found out that, were struggling, or what the issue was with actually trying to make a child?
When we met, after getting married, we had a vision. Our vision was to wait for 4 years or so to finish our studies, pursue our careers. Then after 4 years, we went off contraceptives. And then 2 or 3 years later, we saw that things were not happening. So we consulted fertility specialists. The first diagnosis was on the male side, which was on my side. That was puzzling because I already had a child from a previous relationship. So when I went for the treatments, the consultations, I thought I was just accompanying my wife. But one of the specialists said, no, Baba, check now. So I gave the sample. And then I was surprised when the diagnosis came back. There was 3 challenges. One was sperm count. Second one was the shape of the sperm. The third one was the movement. So that could limit the chances of me causing someone to be pregnant. So that's how we found out our journey of infertility. Then later on, we also discovered that there were female factors. But at first, I was the one who was a patient.
So, such a time is an interesting and also confusing time for a couple that physically you think there's nothing wrong. You're a man, I'm a woman, we know what we need to do to make a child, but the issue is we're not getting pregnant. So in this confusing time where you stopped taking contraceptives and you now find yourself struggling to fall pregnant, what's going through your mind?
At first, it didn't matter kangago what people were saying, or I thought to myself, I wanted to fall pregnant, but we were seeking help, so I wasn't worried about it at first until we tried a couple of treatments, and it then started getting a bit more stressful. That we were not falling pregnant as easy as we thought it would. Yeah.
So I think an interesting thing that you raise is that you previously had a child.
Yeah.
And when someone then gives you a diagnosis of no, you're not or unable to have kids because of A, B, C, D, that raised a lot of questions. So at that point in time, what were the thoughts that were going through your mind with respect to, I already have a child, so why am I struggling at this point in time?
Obviously, we go through the grievance cycle. We deny, like, hell no, it's not possible. I've got evidence, I've got a child. But through reading, research, you come to terms. You understand that once fertile doesn't always mean you'll be fertile in the future. So there are lifestyle, there are events, there are sicknesses that you can pick along the way that can hamper. But at first, I must admit, it was a spin. It was just a curveball that I didn't expect. Yeah.
So you've highlighted something around this idea of you don't care what people are going to say. But, you know, because we're people that live in community, you guys may have expressed to the people that you live with, your families, friends, that, we just got married, we don't want to have kids right now, we're taking our time. But when you've now expressed you want to have kids, but nothing is happening, that creates that anticipation from a lot of people to say, where are the children? So how were you dealing with that as a couple, to say, where are the children? You know, grandparents and all of that.
So when we started experiencing the stress of our fertility challenges, I remember Mother's Day was difficult, being at church on Mother's Day, and they would ask all the mothers to stand. And at that moment, we just had an unsuccessful artificial insemination. And we were just going through a lot, mentally, depression. So whatever that people say, even slight questions like, they become so hurtful. That we would have to comfort each other when we get home. And we started avoiding family gatherings and going out where we will be meeting people because the pressure started becoming too much for us to handle.
Pressure is such an interesting thing that you speak about because it spills over and becomes all the emotional things that you guys would have to go through together. So you spoke to the idea of comforting each other. The psychological element that you had to go through. I mean, socially, the women are the ones that have a problem with falling pregnant because you're a man and men don't have those issues. But this experience obviously opens up your eyes. How did you deal with the psychology of finding yourself having to comfort each other, having to deal with the reality that you actually can't or are unable to currently make kids?
Yeah, psychologically, you need to be strong. You need to build on a relationship with your partner. That becomes a solace against society out there who doesn't understand the background but making demands. And other coping strategy is just to avoid, you know, certain triggers. I remember my lowest point was when I went to a local mall. And then it seems like every second woman was pregnant. And you just wonder, Lord, what have I done? You know. So if you can avoid such, talk to someone close to you, friends, family, there's always a solace or a refugee camp where you can run to emotionally. If you're a spiritual person, that could be prayer, that could be worship. Just take one day at a time. And that really kept us going.
A big trigger that comes with this is, of course, what people say with respect to just the direct questions that they'd ask you. When are the grandkids coming? How? Zipi, Zugul, all those sorts of discussions. What would you say, now that you've had this experience, to other people or people that witness other people's relationships and would say things like this? In a they're not saying it in a, you know, in a negative way or to offend, but what would that be?
First of all, I'd like to say fertility conversations are private to the couple. So people should not, should avoid asking, when are you having children? I mean, you are getting old. People should really stay away from questions like that. But number two, infertility does not equals to infidelity. A lot of men tend to go out and try to have children outside of the marriage when there's a female factor fertility challenge. So it is important for both the couple, the man and the woman, to get checked so that doctors can help deal with challenges that are there. Yeah.
Speak about IVF, a journey that you highlighted you went through. Take us through that journey. How was that in terms of the emotion behind it, the physical stress of it, as well as the financial stress?
Right. So at first we tried artificial insemination because at that time we had gotten a diagnosis that he was the patient, that we had a male factor fertility challenge. So we went for artificial insemination, which is slightly cheaper than IVF. And we had 2 tries, which were unsuccessful. We considered IVF, but it was a bit expensive at that time for us. And today it's ranging between 80 and 120,000 rands a cycle. And I later found out that I had an autoimmune disease called antiphospholipid syndrome, which was also the cause of our early recurring miscarriages that we had. Yeah.
Thank you so much for coming through and sharing this journey with us. I think having people practically, people that you'd walk past on the street, describe this journey to them. For a lot of couples that are probably sitting at home struggling with the very same thing is very important. And thank you so much for coming to share your story with us. That, of course, is Pastor Zwane and his wife, Karabo Zwane, who's joined us today to share their journey on infertility. After the break, we'll speak to Molatelo, who is a multiple international award-winning filmmaker and entrepreneur, about her infertility journey, as well as the documentary, When Babies Don't Come. Stay with us. Welcome back to Vital Signs. Multiple international award-winning filmmaker and entrepreneur Molatelo Bossman has spoken out about her infertility through her documentary film, When Babies Don't Come, where she documents her 10-year struggle with infertility. Through the film, Bossman has not only inspired many people, but she's also given a voice to many men and women with the same condition. Let's chat to her and find out what her story is. Thank you so much for joining us today.
Thanks for having me.
Good. So let's talk about your infertility journey. Here you are, young woman, you want to get pregnant, it's just not happening. What was that for you?
Sure. It broke everything in me because remember, as a young girl growing up, you have aspirations, you have dreams, and I knew being a mother was one of the things that I wanted to be. And here I am at the prime of my career. I was ready to give birth, and now the news break. You can never fall pregnant naturally. That killed everything in me. For a long time, the longest time, I wake up in the morning, I have this knock, just remembering that that dream can never come true. Yeah, that was shattering.
We spoke to the Zwanes just now, and theirs is a story of a couple and the experience that they had. So you were someone in this case who is someone that has to psychologically deal with all these issues because you're experiencing all these sort of things by yourself. How was that, the psychology that goes behind experiencing such trauma?
I mean, remember at the time I was dating and, and the idea actually of, starting a family came with the boyfriend. So here I am. All I'm thinking about is, I don't want to lose this man. He wants a child now, and I must give birth now, and now I can't. So, yes, I'm struggling with the idea of saying I'm coming to terms with this news, but also, the pressure, not just from him, but also from the society that I live in. So it was just, it's not something that I would really wish to my worst enemy.
So here you are, you experiencing this diagnosis, but also the psychological effects that come with it. You're trying, you want to try, you want to have kids, but there are other ways that people would obviously speak to if you are not having children or you can't have children. They'll tell you surrogacy or go adopt a child or just be someone that doesn't have children. What directed you to make the decision that you did make?
I'm glad you're raising that because, for a good 10 years, that's what consumed me. Because for me, motherhood is all about giving birth. You know, I remember in the film, I uttered the statement, I just want to breastfeed because I was consumed by this breastfeeding that will ultimately make me this woman I always dreamt of. But, you know, years later, I started raising my sister's children. That time, I was married now. So it was easy for me to sort of, you know, be in that space because now I have a supporting partner. And today, as I speak to you, we are raising two of my two sisters' children. And I look back and I'm like, why did I put myself through that? Because that, you know, that longing of want to be a mother has suddenly gone away. And I'm thinking to myself, I should have gone for adoption long time ago. So, yeah, so I look back and I say, I shouldn't have put myself through that.
Let's talk about the film. So here you are going through this major life trauma of finding all of this out. And you decide, I want to document this. I want to put this in film so that my story isn't just my own, that the world can see. So what goes into the process of making this film? Take us through that journey.
The news about my infertility came in 2006. So it took me a good 2 years because here I am, you know, from the outside, I'm this perfect looking young girl with a booming career, whereas deep inside, I was going through this struggle. So, and you remember, especially in Black communities, infertility is hugely stigmatized. So here I am, and I'm thinking, I think I have an opportunity now as a storyteller, as a filmmaker, to share my story with the world, hoping that in my sharing of my story, I will be able to give voice to the voiceless, give face to the faceless. So it took me 2 years to finally get to the decision, I would do this and I would do this for the sake of my own sanity. Because through the making of the film, I was able to heal. It was just therapy in itself. And you look at me today and I say, how did I turn this lemon into lemonade? But I had to go through that healing process. And today, I really thank God that I took that decision because it really helped me a lot. Because you know, you meet friends that you haven't seen in a long time. And the first thing they see you is, how many kids do you have? Are you married? All that. So I don't have to answer to that. My story is out there.
What's interesting about what you've done is that you, by creating this film, is you've allowed people to experience the healing or experience the journey that you went through and not feel alone, not feel like there isn't a light at the end of this tunnel and that there is success or there is life beyond this point, as difficult as it may be. And thank you so much for joining us today and coming to share your story, When Babies Don't Come. That is the documentary. And of course, you can go check it out yourself. An international award-winning documentary, that one. And of course, speaks to all things infertility. After the break, we'll speak to Professor Thabo Matsaseng, a gynecologist and obstetrician who's also the head of Reproductive Medicine Unit at Stellenbosch University, about infertility in women and men and the new modified in vitro fertilization procedure at a fraction of the price. Remember, you can be part of the show by asking the guests that we have on any question that you have on your mind by simply sharing your view on what we're discussing. The number to call is 011-714-5861 or 011-714-5877. Going for a quick ad break. We'll see you after this. Welcome back to Vital Science. Now, infertility, the inability to conceive or sustain a successful pregnancy, affects more than 48 million couples in the world. Of these, 10 million live in sub-Saharan Africa. Now, the prevalence of infertility is much higher in developing countries than in the developed world, and this is due to several factors, including poor access to assisted reproductive techniques and proper health care. Now, many people may delay fertility treatments, fearing the cost associated with these procedures. Even though infertility issues can affect both men and women, women often shoulder the bulk of the stigma and, of course, the blame that comes with being in a couple that can't conceive. Alarmed by the cost of infertility as well as fertility treatment, Prof Thabo Matsaseng, a gynecologist and obstetrician, as well as the head of the Reproductive Medicine Unit at Stellenbosch University, came up with a modified IVF treatment at a fraction of the price, giving childless couples a better chance to become parents. He talks to us about infertility, of course, in men and women, and of course the modified IVF procedure. Thank you so much, Prof, for joining us and really coming out to really have the discussion that we're having today. So let's talk about it. What is infertility and what are the different types of infertility do we find?
Yeah, thank you very much, Musa, for inviting me, and just say hello to your listeners as well. I think that you've already highlighted many of the problems that couples faces. But I must emphasize that, yes, infertility, you're talking to heterogeneous couples, people that talking male and female in larger context. But you know, it's not only those people that faces a desire to have or to form a family. So we actually have to be aware that the fertility care in general might actually include other society or other persons, despite their marital orientation or their sexual orientation or their gender identity. So you have to include the LGBTI groups, where you have same-sex couples that desire to conceive, and there are other people that will have other challenges over and above what I've just mentioned. But in simple terms, when you talk about heterogeneous couples, meaning men and female, you're talking about infertility being inability to conceive after at least 12 months of adequate sexual exposure, meaning people that are living together, trying to conceive over a period of time. And that's 12 months by definition. And that always varies because it's an epidemiological data. If you look at time to pregnancy, other ways of looking at how you define infertility, that can always vary from geographic region and to societal perspective. But in simple terms, we say if people are struggling to conceive over a period of 12 months, following adequate sexual exposure, that's infertility. And I'll pick on what your previous speakers have mentioned, that the Zwane family, that, you know, I always simplify and approach to infertility that don't make it too complex. All you want to know is that what does a couple need for them to achieve a successful pregnancy or achieve the desire to start a family? It's all from the female. All you need being a tubes, the fallopian tubes, and you need an egg from that individual, and you need a sperm from a man, because all the natural conception, they start in the fallopian tubes. So the sperm and the egg will meet in the tube, and that embryo that has a potential to become a baby will have to implant in the womb, and eventually the baby will be born if there's no miscarriage in an unfortunate situation. So in simple terms, if there is a difficulty to conceive, the primary aspect where you're going to look, is it a problem with the eggs from the lady, or is it a problem with the tubes, or is it a problem with the sperms? And in that being said, you have this proportion that has been laid out, that in what proportion would you blame the eggs, would you blame the tubes, would you blame the male? So in general, from the data we have, we say from the female aspect, you look around 10 to 15% being problem with the tubes, and then it'd be another 10 to 20% being the problem with the eggs. And then of course you'll have another third being, or 10 to 20% being from the male. Or you'll have a group of individuals that we named as unexplained. So meaning you can't identify the actual reason why these people can conceive. And unfortunately, where there's a combination of a male and a female factor, male contributes significantly to that proportion. And I'm so excited that Pastor Zwane has at least highlighted that factor, because it's always a female problem until proven otherwise. And that's a societal, the society, how it constructs the whole thing, or the norm, how it's perceived. So I'm so excited that he put it out there that yes, men have to own up to the possibility that yes, there could be a male infertility contributing to the whole side.
Prof, are there red flags or things that people need to be on the lookout for with respect to, thinking that they might be infertile or finding out they're infertile? I think the issue comes with the idea that, it is mostly a silent disease or silent disorders that exist with infertility. No one knows that you're infertile. So most patients that have, for instance, diabetes will know that they've got diabetes because there are actual physical things that happen with them that point them towards that sort of diagnosis, versus with things such as infertility, you won't know until you're trying for a child. So what should men and women look out for, if there is, in terms of finding potential problems?
Yeah, I think that's a very good one, Musa, in the sense that, you always try and look at profile, and that profile, what you just mentioned, how do you risk this? This couple say you are either a low risk to be infertile or you are high risk to be infertile. And I think looking at all the aspects that I mentioned, from the male point of view, it's very difficult to be able to say this person, is he a potential problem, or what must he look for that being a potential? And I think there could be a wide spectrum of factors starting from the male. So if you take a young man who give you a history, that yes, I'm probably the only son in the family, and my parents took so long for me to be conceived. Then you start picking up the red flags. Could I be the problem myself from the sperm point of view? Two, the history how the child developed from childhood, whether there was any element of mumps that this young man had as a child, because that mumps could have translated to some degree of colitis, that might be an issue for him. If there's any history that he had some illnesses, either being admitted in the hospital from any head injuries or infections that related to the central nervous system or related to the genitalia themselves, any history of sports injuries, if you have been a high intense sportsman, or if you have been a competitive sportsman in the sense that you do a lot of sports activities, that include induced drugs like steroids. So those people are pretty much the high risk group that we say, maybe I could be a problem in trying to conceive. And by far, if you are an obese individual with lack of exercise or bad, or let me say not bad, but poor lifestyle, smoking, drinking, so you might actually profile yourself that, listen, I might be a problem. If you look at a female point of view, and I must pick up on, I'm sorry that I'll pick up to the Zwanes again, because they gave us a depth of the problem. From a female point of view, age is fundamental to everything. And I know women find themselves in a very difficult situation that I have to build my career, I have to be independent before I can start a family. And that alone, it's a major, major red flag, because many women start their reproductive career at a very late age. By that time, the quality of the eggs, it's beyond what it can translate to a possibility of having a child. So if you are a female and you know the age-wise that you are much older, then you must start having red flags. If the age is not an issue, what could be the other factors? Your menses. We always say we pick up on, could this be a problem with the eggs? If your menstrual cycle is a problem, either they are irregular, they are sometimes not there, or they are not there at all, that is also a red flag that yes, there could be related eggs issues with you falling pregnant. And if that's not the case, from the truth point of view, that might be difficult because everyone has some degree of discharge, some degree of low abdominal pains there and there. But if you have been exposed to repeated infections and you have been treated for this so-called vaginal discharge or low abdominal pain, that also a red flag that, listen, there could be an issue with your tubes being at risk, or you had some exposure of being pregnant, and at that time it wasn't the right time, and you resorted to an adoption. And if the adoption was done unsafely, that could be also a risk for you. either being the womb damaged or the tubes being damaged in that space. So it's very critical to have that kind of insight, especially as an individual. But many of our people don't have that educational awareness, which is key to how people identify their risk before they could even say, let me take my time trying. If you don't have that kind of argument or insight, rather consult early if you want to get married and want to start having children. Rather consult and say, am I at risk or am I not at risk? Then be reassured and say, no, you're not at risk, go try. Or you're at risk, let's rather find out much earlier what the problems could be.
With the issue of infertility, of course, it comes, as you've described, with not being able to fall pregnant within a year period with adequate sexual exposure. Once you've gone through the year and, you haven't fallen pregnant as a couple, what is the next step? Where do you go? Who do you go see?
Sure, Musa. I think as a basic, people consult various ways of trying to conceive. And listen, we all have our own beliefs, our own perspectives to life, as to consult culturally, first meeting the traditional approaches, or do I go Western and go find out? And I think the safest for me, and I'm talking from both worlds. I mean, I'm African, I grew up in Africa with a cultural background, but knowing what I know is that it's probably much safer if you do not want to consult the doctor directly or don't want to consult the specialist directly. Rather go to the nearest clinic and find out. I think from what the society has constructed, women find it much easier to speak to the healthcare professional than men. Men always try to hide behind the problem for much longer. So if that's a situation and you have other colleague or other men to speak to, rather consult your peer who have been in the space or not been in the space, then they can lead in the right direction. But overall, I think it is best to consult the healthcare professional, either at the clinic level, to find out where can I go from here. If you have access to medical insurance or you have a family practitioner, go directly to a family practitioner. Those are the first people to go to because they have insight to direct you from the start as to where to go. They can always reassure you as a couple that, no, we don't think there are red flags. Try 1, 2, 3, 4, that we can elaborate on this talk as you allow us to. Or you can say, no, I think for now, there is some serious red flags. I'd rather refer you to a specialist much quicker for further workup, and they can determine what the actual problem is. So as a start, I'll say your family practitioner is probably the best to go to person. If you don't have an access to a GP, you are somewhere in the village or far from healthcare workers, go to the nearest clinic. But traditional approaches, we don't say don't, but remember there is no facts around that, and there is no actual scientific proof that whatever you're going to try, is it going to translate to your dream or to what you desire? So, and I cannot discredit the traditional medicine in any form, but I wouldn't recommend as a start unless it's your belief, and that's what you want to start from.
Prof, let's speak about reproductive technologies that exist and are available to couples that are finding themselves to be infertile. What procedures exist? What is it that can be done to assist these couples?
Yes, Mosa, this is pretty much a very global approach. I'll give it to you, to be frank. And remember, it's always going to be limited by whatever resources you have or whatever access you have to care. And remember, this is becoming a global movement in a very much way that in any form, whether you're looking from the European approach or from North American, there is this desire or drive to access to care and simply trying to achieve many of what has been said as a sustainable development goal to say, can we improve the well-being of the people and access to equal health care? That should be the start. And two, in whatever universal coverage of health you're talking about, can you include infertility as a disease? Because many of the treatment options that are available, that are effective, are actually limited by access and by affordability. But that being said, if you look at the simplest way of looking at it, if you see a couple and you establish, and this, remember when I started, I say we have all different spectrums of persons that desires to start a family. It could be the same sex couple, be man to man or female to female trying to build a family. Those are a special group that will need assisted reproduction from the beginning. But if you have a man-female and you have established that, yes, there might not be red flags here in terms of the tubal disease or the egg problem or the sperm problem, all what you can advise is, can they try some sort of stimulating the eggs and try a timed intercourse at home? And this can be at a very primary level, meaning the clinics or from a family practitioner say, couples, you can take this type of tablets, being whatever the tablets to start building the eggs, and we give you that time or the time where you are most fertile. We call that fertile window, and try around that period. It's a simple guidance that the people can try. And for how long can they try that? We say minimum 3 months to 6 months of them trying. If they fail to conceive, what will be the next step? And this is where it becomes an individual approach to say, can they do artificial insemination? Meaning they will take the tablets or some injections in the aim of stimulating building of the eggs. And once that process has begun, you can time when to get the man's sperm to be washed, and that sperm is placed in the woman's womb to be able to be closer to where the eggs are, and then they conceive through that method. Artificial insemination, how many times can you try? At least 3 times, or 3 months to 6 months. But remember, once you start moving to artificial insemination, now you're talking cost and you're talking inconvenience because they have to come now for follow-ups. And from artificial insemination, then you talk IVF or other form of in vitro fertilization, whether being done for the tubes that are damaged or it is done for a poor sperm from the man. So in that space, meaning that individual or the female will get the injections to build the eggs, and those eggs will be harvested or be retrieved from the ovaries. The man will give us a sperm in the form of masturbation, or that sperm can be retrieved through other methods. And if the sperm is normal, we will leave the egg and the sperm alone. That is IVF. If the sperm parameters are very abnormal, there will be an effort in the lab to inseminate those sperms directly inside the egg to ensure that those eggs are fertilized. And that's a process we call ICSI. So every step of all the process will be based on what is the indication for treatment. And that being said, jumping from trying on your own at home to IVF, it's always seen as a big jump because of the cost. But at some time you must realize, Mosa, you can try on your own in your own comfortable space, as long as the sperm is normal. The tubes are not a problem. The eggs is not an issue at that particular time. It is probably best to do that method in your own convenience, as long as you are timed very well in terms of fertile window. The success is almost 20 to 25% after 3 months of attempt. If you talk artificial insemination and you take people, say now you fail with the home plan or timed intercourse, go for artificial insemination. You have to be honest with these people and say, you're gonna do it for 3 times. At what possibility or probability of getting pregnant? It's only gonna be about 25 to 30%. So the margin of difference is only 5%, and they start to pay. And artificial insemination in private practice, it will cost you minimum 8 to 10,000 bucks. Are you going to spend 10,000 bucks for 5% difference? It doesn't make sense to me as an individual. But there is a fast track approach that if you have tried on your own and you couldn't succeed, look at IVF. IVF, it should not be seen as the Mercedes-Benz or the Rolls-Royce of getting pregnant. It's just but one of the methods that should able to cut the time to pregnancy to at least shorter period of time. Unfortunately, because of the cost and access, it's a barrier to many of the people. So they rather go try an insemination 3 times, spend at least 30,000, and after all, if it doesn't work, I wouldn't be able to tell why it didn't work, because I didn't know whether the egg was out, the sperm was there. But with IVF, at least you'll get that tactile feedback either your eggs had a problem or it was a poor embryo development, and how can you strategize from there?
Prof,
But
I'm going to have
because
to
of
jump
the
in there and interrupt you, but I think for the past 20 minutes, I think you've given us a masterclass on what, infertility and the treatments that come from that are. I think it's important what you've done at your center as well with respect to pioneering and really making the cost of getting IVF cheaper, highlighting that there are alternative ways in which people can go out and be able to turn their infertility into a potential fertility and really assisting all the couples that you do. But of course, if you'd like to find out more information about that, use your phone, take that, Google, and find out for yourself. And of course, you can get all the help that you need. Thank you so much, Prof, for joining us today and really highlighting those points. We're going for a quick ad break. We'll see you after this. Welcome back to Vital Signs. In South Africa, fertility occurs in 15 to 20% of the population. That's 1 in every 6 couples, and most turn to surrogacy or adoption to become parents. But under the country's labor law, do these parents have the same rights as conventional parents to take time off from work, to care for their children? And of course, we're joined by Professor Zozo, Nene, the head of the Reproductive Endocrine Unit at Steve Biko Academic Hospital and the University of Pretoria. Joins us to talk about infertility, which is a practical concern of Africans due to the social disgrace and exclusion that generally comes with it. Thank you so much, Prof, for joining us. I think let's jump right in and talk about how prevalent or how much of a problem is infertility in South Africa.
Thank you very much for the invitation, and good morning to everyone. Firstly, we use the WHO estimations of what the prevalence of infertility is. And the WHO has estimated it as 1 in 6 couples that suffer from infertility. But this has been data from the demographic and health surveys from different countries. And in South Africa, we really don't know what is the prevalence. So we use the WHO prevalence data. But there is a study that is ongoing at the moment where we want to answer exactly that question. What is the prevalence? How big is the problem? What are the causes? And hopefully by doing that, we'll be able to allocate resources towards the disease of infertility.
Let's speak to the stigma of infertility. I think with the guests that we've had on the show, one of the big themes that ride throughout is this idea that what is society saying and the stigma that comes with it. So from all your years of experience, what is the biggest problem that patients would come to you and complain about?
Firstly, I really just want to take my hat off to Pastor Zwane and Karabo for coming through with their problem, because this is really a painful issue and it is a very personal issue to discuss. So people are stigmatized in their community because it is believed that you need to have a child, and that sort of cements your societal value in that sense. So you find that people don't want to discuss infertility, that the fact that they are unable to have children because the society, the community, they are stigmatizing them that they don't have children. And they resort to things like, in the cultural way, they try to deal with it, as in they will find a wife for the husband, another person who will have the baby. Or if they think, and for the most part in our communities, we don't think males have a problem of infertility. It's always the women that is to blame. But in a sense that when they try to have other wives for the male partner and nothing is happening, then they realize it's probably the male partner. Then they will try to get the brother or someone to have a child with the wife. So, but the biggest problem with stigma is that it prevents the people from talking about this disease of infertility. And not only that, they are suffering alone. And secondly, they do not access now the service. They are not going to go out and look for help. So there is that delay that they experience in trying to seek the service. And by the time we see them, especially in our clinic, they have suffered with this problem for such a long time without talking to it. So this is a barrier to accessing the service. and it is the problem of stigma.
Let's speak to this idea of education, which you're highlighting, but also the solutions that come with it. A lot of the people in the country generally can't afford private healthcare with respect to going for artificial insemination, for having IVF and things such as that. So what about the rural person or the person who can't afford to go to private? What does the state do in terms of services that are available to a couple that wants to fall pregnant but just can't afford it?
All right. At the moment, there's not enough messaging, I think, to educate the public about that there is such a service, first and foremost. So we are going very hard on trying to give the message. And in fact, the most important thing is to educate the healthcare providers in terms of helping the people that are suffering with infertility. So there are guidelines that have been developed. The government has come up with a policy document now, an infertility. I'm trying to show the document now. It's available on the departmental website, that infertility now has been identified as a disease, and it is in the policy that the services must be available. And then a step further was the development of the guidelines for infertility. I'm going to try and show that again. Also available on the government's website. And these are recommendations on prevention of infertility, because the first thing, you must prevent infertility. And they've spoken quite a lot about safe sexual practices, the sexually transmitted infection, stopping smoking, health style, avoiding, health style issues like smoking, alcohol. And this is prevention. It also makes recommendation about the treatment, the investigations, the treatment, how to access it, where to go, because we find that that's the biggest problem. People don't know where to go and how to access it. And this is saying what can be done at a primary healthcare level, at the clinics, the GP, and what can be done at a regional level, and when to refer, and what are the referral routes. And this we've already also developed a training package for healthcare providers so that they know exactly how to refer these patients. And we want to stop this delay in seeking the correct services. So we have gone to all the provinces to train the healthcare providers. We were in Northern Province in April or March, and we trained about 4 districts there, the healthcare providers in those districts. Because we want the information to disseminate to the level where every South African has access to this information and they know how to access the service.
Well, Prof, thank you so much for joining us and sharing that very important information. I think it's so important to know that just because you are living in a rural area or can't afford private healthcare, that you, if you're experiencing infertility, can still go out and have children. But also, I think highlighting throughout the show this idea that we've had that there is surrogacy that's available. There's IVF, artificial insemination, and of course, adoption that exists for couples that are looking to have children. Thank you so much, Prof, for coming and really highlighting that issue and, of course, those ideas to us. Thank you to all our guests for showing us what they've experienced, what their lives were like, and of course the doctors that came through to explain all these problems and of course the solutions that come with it. Thank you for joining us. From us here at the Vital Science team, goodbye.